Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, and this is Cardiology Seminars brought to you by Triple N Media from Houston, Texas. We have more than 170 lectures on our YouTube channel, and we welcome you to watch each one of those. And this is one of the chapters from the Cardiology Rounds manual I have created, which has approximately 140 pages. And at the end of presentation, I'm going to tell you how you can get a free copy of this cardiology manual. In this presentation, I would like to cover how we measure left ventricular function, namely systolic function, diastolic function, and also myocardial perfusion. And we use a number of different tests to get these informations by using echocardiography, nuclear imaging, CT, MR angiogram. So we do PET scans, which goes along with nuclear studies. Let's look at the echocardiogram. Echocardiogram has the flexibility of being a non-invasive test which can be done at bedside, and within 20-30 minutes we can have a complete comprehensive review of left ventricular size, left ventricular thickness, left ventricular wall motion abnormalities, overall global left ventricular function, both systolic and diastolic. The advantage with the echocardiogram is we can get multiple different angles and views which are possible in echocardiography and also in MR studies. Here we have the 4-chamber view of the left ventricle looking at the lateral wall and the septum and the apex. We have a 2-chamber view which looks at the anterior wall and the infralateral wall or the inferior wall, and we have a long axis which looks at the septum and the inferior wall. And if we put this picture together, as we can see, the septum is represented here and the lateral wall is represented here, the cross section of the ventricle. Then we have the inferior wall and the infralateral wall here. And when these segments are taken from the apex all the way to the base, they are divided into like 4 segments, and they become like a donut, going all the way from the apex and superimposing each one of these segments. So this represents the anterior wall, this represents the septum, this represents the inferior wall, and this represents the lateral wall. Of course, it is anterolateral and infralateral, inferior, infromedial, infroseptal, anteroseptal, and anterior wall. And looking at each one of these segments, we can look for regional wall motion abnormalities, and looking at the end systolic and end diastolic volumes, we can calculate the left ventricular ejection fraction. By doing these studies, we can get a very accurate assessment of what the left ventricular ejection fraction should be. The normal ejection fraction is anywhere between 55 to 70%. That is, it ejects 55 to 70% of the blood during each cardiac cycle. This is from an echocardiographic point of view, and we get similar information from a nuclear perspective. I'll come back to this diastolic function. From a nuclear perspective, and nuclear scans are done a little differently because we inject an isotope which is picked up by the myocardium and which lights up like this, and then we take the images in multiple angles and reconstruct these images so that they sort of match what we see on the echocardiogram. For example, we have the anterior wall here, we have the septum here, we have the inferior wall, and we have the lateral wall. And when you look at the horizontal long axis, that is, we have the septum, the apex, and the lateral wall. When we look at the vertical long axis, like the vertical long axis, we are looking at the anterior wall and the inferior wall. And as you can see, if it's completely uniformly lit up, that means the perfusion is normal, and if there is a missing segment, that means there is an evidence of scar in these regions. Looking at the end systolic and end diastolic volumes, we can get left ventricular function, but we won't be able to assess any wall motion abnormalities in this study to the degree we can do it with echocardiogram for that matter. And the biggest advantage of the nuclear perfusion studies is to look for any evidence of myocardial scar or reversible ischemia. We are putting the same pictures going from the apex to the base. One is the stress, and this is the rest images. This is the short axis, and one of them is a horizontal long axis. The other one is a vertical long axis. So we can sort of pinpoint the region of myocardial perfusion that is showing ischemia or scar, and then we can correlate that with the angiographic findings in the cardiac catheterization lab. We also get a fairly accurate assessment of the systolic left ventricular function here, but we won't be able to assess the diastolic function. The CT and MRA have a similar approach in terms of slicing through the heart to arrive at the same information. And one of the advantages of the MRA is not only can we look at myocardial perfusion, we look at wall motion abnormalities, we can also look for any evidence of scarring or calcification within the myocardial tissue, which may suggest evidence of either previous infarct or presence of infiltrative cardiomyopathy. So this way we can evaluate the left ventricular systolic function in a very accurate fashion by using a variety of these tests. And let's get back to the diastolic function. To assess the diastolic function, we primarily use the echocardiography, especially the pulse and tissue Dopplers. And here we can see a Doppler is placed at the level of the mitral valve, and here is the mitral valve E and A relates to the atrial contraction. This represents the early filling of the ventricle, and in a normal situation we have a E which is much bigger or taller than A wave, and the tissue Doppler, which is by measuring the tissue velocity by placing a pulse Doppler on the interventricular septum or the lateral wall, we get the tissue Doppler. From there we get a sort of a mirror image of what we see in the mitral inflow Doppler, and you get a similar pattern here which sort of mirrors pulse Doppler. This is a normal function. And in patients with elevated end diastolic pressure, we know there is increased resistance to ventricular filling, so the atria have to contract vigorously. That produces a much bigger deflection, so the E becomes smaller and the A becomes more prominent. This is phase 1 of delayed diastolic relaxation, and it sort of mirrors in the tissue Doppler. So these two sort of mirror each other in the tissue Doppler. Whereas when we get to the second grade or pseudo-normalization, that's when the diastolic function is getting worse, where the ventricles can hardly expand, and the resistance is not making a big difference in terms of getting the blood across the ventricle. We see the E becomes taller and the A wave becomes smaller, but in a tissue Doppler, both of these are sort of diminished. And that's one of the hallmarks of this stage 2 or pseudo-normalization. Whereas in a far advanced irreversible stage, which is a restrictive pattern, like what we see in patients with infiltrative cardiomyopathy or in patients with severe diastolic dysfunction, the E becomes pretty prominent, at least 2 to 3 times bigger than the A wave, and the A wave looks very small, and it is also associated with the diminished tissue Doppler velocities. So putting all this thing together, we can not only look at the left ventricular size, we can look at the left ventricular volume, we can look at the regional wall motion abnormalities on the echocardiogram, we can measure myocardial perfusion, we can look for evidence of scar calcification within the myocardium or infiltrative process, we can look at the systolic function and the diastolic function, and that will give us a pretty accurate assessment of what is happening inside the patient's chest and how it is affecting his cardiovascular system. I hope this has been useful to you, and please do subscribe to our YouTube channel. In order to get a copy of this book, I would just say send me an email, and here's the book. And if you want to get a copy of this book, I would just say send me an email to drniknikam@gmail.com, and I'll be happy to send you a copy of this. And please be sure to watch 170 to 180 videos we have on various topics covering in the entire cardiology. In fact, everything that is here are covered in those videos.